So I chose not to have any slides for this and really open it up for a dialogue. That's why I wanted to be able to see everybody. And Yolanda, you can't turn your camera off. You have to turn it back on. Yeah, same with Eugene. So I'm going to give you a update on 3 items. I'm going to talk first very, very briefly about our CLL project, and I hope that you reach out and watch the recording from Andrea that is going on right now. You can watch that later, but as I introduced Andrea earlier, she's a medical oncologist. She works with Danielle Brander, who is the head of our CLL team, chronic lymphocytic leukemia. We've really developed a wonderful, robust team, including one of our medical oncology fellows, Heather Wolf, working on a number of projects, looking at how we can extend and optimize the lives of our CLL patients. The average age at diagnosis of CLL is 70. These patients will often live 10 to 15, maybe 20 years on therapy, but often have multiple problems, both related to their CLL as well as our treatments. And so our goal is really linking them and their primary care provider. For example, we recently did a study where we looked at blood pressure in this population. 2/3, 2 out of every 3 of our CLL patients either has uncontrolled high blood pressure or new onset high blood pressure. And so we've created a mechanism to loop them back to their PCP to manage this problem. So if you get a chance, do watch that recording, well worth it. The second exciting new program that's starting up is led by Scott Schofer. Scott's a pulmonologist that's worked at both the VA and Duke. And Scott developed a pulmonary rehab program for our patients with lung cancer. And we're taking that same program, which is largely virtual. We do an evaluation at the cancer center, and then we have virtual visits for 8 weeks, and then a wrap-up session. And we have an exercise physiologist, a dietitian, a behavioral scientist, smoking cessation, our nurse practitioners, all that working with improving the health of our lung cancer patient population, both before, during, and after their surgery or their therapy. And so we'll be launching that program at Duke in October, and working with Tommy D'Amico, our lead surgeon for our lung cancer group, Jeff Crawford, our lead medical oncologist for our lung cancer population, and their teams. I'm really, really excited what Scott is bringing to the table with that effort. The last one I'm going to mention is actually, to me, the whole purpose of Onco-Primary Care, and that's our One Team grant. And I've had the honor and pleasure of leading a number of large studies over the last 20, 25 years. And this is perhaps my favorite team we've had. We have an incredible team of people that are oncologists, primary care providers, population health scientists, and I'll describe what that means in a second, behavioral scientists, biostatisticians, people working with our disparity issues, etc. My co-lead in that study is a person named Leah Zulig. Leah is a population health scientist. That means she got her PhD in understanding things at a large population level. And her expertise is in chronic cancer management, chronic disease management, adherence to therapies, and what we call dissemination and implementation, which means after you finish a study, how do you keep it from being a one and done? A lot of our studies, you do it, it's great, you find findings, you publish them, and nobody pays any attention to them, and it's one and done. And what our goal with this project is really have something that is generalizable in multiple settings. So what we are hoping to do in this study is enroll 800 patients. We'll start enrollment in January, probably actually in virtual enrollment because of COVID. 800 patients that are being diagnosed, recently diagnosed with one of 6 different solid tumors: breast, prostate, colorectal, lung, endometrial, and head and neck. At either our Duke Durham, Duke North, which is our regional hospital, Duke Raleigh, and 2 of our Duke Cancer Network sites where we have majority minority populations in that area, a high concentration of both African American patients, and also American Native Indian. And that's in Lumberton and Laurinburg, south of here by about 90 miles for those of you that grew up in the North Carolina area. I still have to visit them. We're waiting for COVID to get better for us to actually be able to do an in-person visit, but we're excited to work with them. And what we're doing in this study is we're actually taking people that either have high blood pressure, cholesterol problems, or diabetes when they're diagnosed with one of these 6 cancers. And we're telling the patients, your primary care provider is important day one, not in 2 years, not in 5 years, but right now. They need to be the one managing these 3 problems, not your oncologist. Your cancer care is complicated. Your oncologist is really devoted to giving you the best of care. And your primary care provider is the right person to be able to manage these 3 problems. And we're reaching out to the primary care provider and saying, you are the person that's responsible for these 3 problems. Because indeed, all 6 of those cancers, patients nowadays, because of the advances of our therapy, are more likely to die of a heart attack or a stroke than their cancer. Let me say that again. You've heard me say this so many times. Patients with these 6 cancers are more likely to die of a heart attack or stroke than they are from their cancer. And so we're really empowering our primary care providers and saying, you are part of our one team. It's the name of the grant. And so we're very, very excited to be able to put into motion what we've envisioned now for a couple of years. It took a lot of relationship building. We'll have primary care providers that practice in the Duke Primary Care Network. We'll have people that practice around Warrenburg and Lumberton. We'll have primary care docs that are in Asheville, on the coast, in Virginia, in South Carolina. People that roll their eyes when they hear from us, and we will pester them to make sure that we get the best of care for our patients and monitor how they do and how our patients do on there. We have an incredible team for that. Rachel Greenup is one of our breast surgeons. Yusuf Safar is a medical oncologist. The 2 of them are very interested in cost of care. We actually think that we will lower the cost of care for patients and avoid unnecessary emergency department visits, unnecessary hospitalizations, as well as lowering overall cost. And so the 2 of them are working with Michaela Dinan, another one of our population scientists, to do a very sophisticated look at cost within that area. We have primary care providers, including Kevin Shaw. Kevin is the leader of our innovation for Duke Primary Care. He's an MD, MBA, so business background, incredibly bright guy that practices at Duke South Durham and has been a huge leader in what we are doing with that. We have an incredible advisory board, including the CEO for ASCO, the American Society of Clinical Oncology. When I asked Cliff Hudis to be on our board, he said, we don't normally get on the board of grants. I have to have that go through our ASCO board and agree to it, and they all thought that this was important enough to do. We have past presidents of the American Academy of Family Physicians, leaders in Society of General Internal Medicine, people in oncology, nurse practitioning, and PA, patient advocates, et cetera. So a really incredible advisory team. So I wanted people to have their cameras on, unmute themselves. This is a chance for dialogue. I gave you 3 examples. There's a lot of other things that are going on in this space, but you give you a chance to ask questions, make comments. Say, Kevin, when are you going to do X, Y, or Z? You promised this 2 years ago. Where are you with that? So unmute yourself, have your cameras on. Yolanda, I'm still waiting for your camera to come on.
Yolanda's having some tech difficulty on her end.
Oh.
Yeah.
Yolanda makes me look good because I'm always in the right place at the right time because of her. I've told her many times, I've worked with administrative assistants for 25 years of my academic career. She's number 1. She's absolutely incredible. Our patients love her. My colleagues love her. I love her. I couldn't do all that I do without her.
Well,
So,
thank you very much, Dr. Effinger. That was very kind of you.
Kelly, Arlene, Janet, Jean, Laura, Jamie, comments, questions, observations? This is your
The only comment I want to make, and you're not going to appreciate it because it's not a question directly about that, but your beard looks great.
Yeah, I was expecting one of those big scruffy beards. That you were
Yeah.
like,
It really is very becoming. So just
it is.
Patty always said that I made myself look older with it, and I think what she really meant is I made her look older. So she looked at me with a beard.
it's very nice though. Not everybody can pull it off that way. So.
Thank you so
Yeah,
much.
it looks very good. Looks very good on you.
Yeah.
Thank you.
Now, Dr. Oeffinger, you have done a couple of other studies which have involved primary care facilities to help increase the knowledge of some of the comorbidities that surround, post-cancer treatment. So I know you had the Empower study, and I thought that one was really cool. Can you just talk a little bit about what has been done to this point to help educate these providers in these primary care areas?
Yeah, the person that I wish was on our meeting today is Renee. Obviously, Renee is our research project leader, and she has been incredible force in both of these studies. She took over this role right as COVID hit us, and Duke froze all of our hiring. And so through both of our grants, we have the dollars for 3 other clinical research coordinators for her to oversee, and we have not been able to hire any of them until I think we have the first one we'll hire probably next week. We've gone through all of the interview process on that. But she's been incredible in the Empower study. The Empower study is kind of cool. Probably my greatest passion is our women who were treated for Hodgkin lymphoma when they were in their childhood or young adult years and treated with chest radiation. They have an incredible number of risks, and I've dealt with that a patient population both clinically. I did a Zoom for our Hodgkin patients internationally earlier in COVID, talking about health problems in COVID. And one of their biggest threats to life is breast cancer. They get breast cancer at a young age. I've had 2 women develop breast cancer at the age of 25. Some of my colleagues have had them in their teen years. And by the age of 50, 1 out of every 3 of these women have already been diagnosed with breast cancer. So we start screening at an early age. We screen with an MRI and a mammogram. So we've been studying how can we both empower our patients, but also activate their primary care provider. This study we actually are doing fully by an app. So there's a smartphone app that the patients enroll on, both iPhone and Android, answer some of our questions, and then they get video vignettes that we filmed a couple years ago that tell them about cost of MRIs and how to get a free MRI, talks about how to talk to your PCP, how to look at the different priorities you have in your life and adjusting that and making yourself a #1 priority.